Specialty Story, session number 20. Whether you are a pre-med or a medical student, you've answered the calling to become a physician. Soon you'll have to start deciding what type of medicine you'll want to practice. This podcast will tell you the stories of specialists from every field to give you the information you need to make sure you make the most informed decision possible when it comes to choosing your career. Welcome back, or welcome to the Specialty Stories podcast. My name is Dr. Ryan Gray, and today we have a brain surgeon, a full-out brain surgeon, talking about neurosurgery. We have Dr. Stephen Grupke, somebody who I went to medical school with at New York Medical College, who is now an attending physician at the University of Kentucky as a newly minted neurosurgeon. So let's go ahead and dive right in and say hi to Steve.
My name is Steve Grupke. I'm a neurosurgeon. I'm in a academic facility. I'm new faculty. I'm an assistant professor at the University of Kentucky.
All right.
And,
go ahead.
Oh, shoot. Already awkward.
Go ahead.
No, why don't you go ahead?
You're good. All right.
Start this off.
All right. I won't hold the fact that you're at Kentucky against you, since I am a Gator. So we'll let that one go. How long have you been practicing now as an attending?
Just a year. So I'm kind of fresh out of residency, although that means I graduated med school a long, long time ago, because our residency is kind of long and grueling.
Yeah, we'll dive into that. When did you know that you wanted to be a neurosurgeon?
Well, so I was in grad school, actually, and I was a chemistry major in undergrad, and I was working in a lab in grad school. Kind of thought I might have a future in kind of benchtop science, and a neurosurgery resident, Mark Horniak, he was sort of a mid-level resident at the time, up at New York Medical College, was in a year of his residency where they allowed him to, take some time off from his clinical duties to do a lab rotation and get some research under his belt. And he met me and took me under his wing, and we were doing, experiments in mouse brain tissue, doing slice prep, and he was telling me about all of his adventures on, in residency and things. And, he took me with him to his grand rounds and showed me videotapes. This is in the long ago. I'm kind of dating myself, but they actually, kind of videotaped some of their surgeries through their microscope, and he'd put together these films for their grand rounds every week and was showing me all this stuff. And I just thought it was amazing, to be able to do this kind of stuff for people and kind of the interventions that they had. So I thought that was awesome and was taken by it right there. I kind of always thought, medical school would be a cool thing to do, but it was sort of an abstraction, up to that point, because, you kind of have an idea as to what a doctor does, and it's kind of a thing that's, in the back of your mind if you're a kid that makes good grades and enjoys science. But, that was the first time I saw, man, this is what doctors do. This is what neurosurgeons do. This is awesome. I would love to do this. So
interesting. So it was the introduction to neurosurgery that prompted the thoughts about medical school.
Yeah, essentially. I mean, I thought that might be what I would do after grad school, med school in general, but I sort of was directionless and didn't really, didn't really have, any sort of specialty that I liked. But, that kind of sold me on the whole, doctordom and everything from the future there. That was sort of my first real introduction, other than a couple of little kind of, short little stints, shadowing a couple of times in the ER and things like that. But, that was the first time I was actually just totally grabbed and engaged.
Very cool. What traits do you think lead to being a good neurosurgeon?
So I think a real key one to have, and that you may not kind of think of going into it, is stamina. And that's, I think, people think of, physically, because you may be in a very long case, you may be, standing in the operating room wearing heavy lead and doing this great big spine surgery that takes hours and hours, or you might be under the microscope, taking out a brain tumor for hours and hours, and that can be very kind of physically and mentally taxing. But the other issue with stamina is, it's very kind of mentally taxing to, have a long clinic where you have a lot of people with a lot of varied problems, and to try to think every one of them through and try to, give a genuine concerted effort to every single person and everybody's very different pathology. And the other thing is emotionally, the level of acuity in what we see is pretty profound. And so, you can have, a lot of highs and a lot of lows all in one day. We can see some pretty horrible things. We see, abused children that come in with brain traumas, and, some, terrible traumas, and, people that are newly diagnosed with brain tumors. And these are all really, really terrible. And you're there, kind of relaying this information to a family and trying to do that. And then on the same note, you can bring somebody from the brink of death with an operation. You can, give somebody function back with a simple spine surgery that lets them, live without pain. There's a lot of kind of emotional highs and lows, and to just deal with that day in and day out is kind of tough.
Yeah, I bet. That's it's something I know back in the episode where I talked to Allison in neurology. It's a very common thing, obviously, and in neurology and neurosurgery, dealing with a lot of the same crossover of patients, and it's just a lot of bad stuff that doesn't really get better sometimes.
For sure, and there's a lot of overlap with neurology too. We work very closely, but like I said, there's also real highs that come in between that, and it's being able to kind of focus on that and move on to the next thing, and do as best as you can for every single person that comes through your door. That and keep pushing, and kind of not let that wear you down over time. That's where the stamina thing comes in.
What's the longest case you've been in?
Let's see. Well, I've been in a brain tumor case that, as a resident, that went 14 hours. And that's one case. Then, we've had spine operations that end up being broken up into a couple of days. A long, complex scoliosis case that it's multiple levels and things like that. That in and of itself, it's if you combine all the cumulative times over the course of a couple of days, they've been longer. But yeah, I think 14 hours in one go was the longest for me.
Wow. As you progressed through your medical school training, were there any other specialties that kind of crept in and were in the running besides neurosurgery?
Oh yeah, for sure. So neurology, for obvious reasons. We share a lot of pathology. It's also very cerebral and thinky, and it's focused on the central nervous system. And I love having to be an astute diagnostician, and everything that entails. I liked having to think up esoteric pathologies to try to figure out. And the other thing that may not be quite so obvious, and a lot of people think is a kind of a polar opposite to neurosurgery, was internal medicine. So I did my internal medicine sub-I, in July of my third year, and I really, really liked it. And I think it shares a lot of things with neurosurgery. Notably, just the complexity of the and the diversity of the kind of cases you see. There's a big case mix. There's a lot of detective work involved. You see a lot of different specialties. In neurosurgery, one of the things that really drew me to it was you have to know a lot of varied information about a lot of different specialties. You have to know, endocrinology for pituitary tumors, or traumatic brain injury patients that get SIADH or cerebral salt wasting, or, you have to be kind of adept at, critical care management. You have to know, so many other specialties. You need to know, kind of fluid and electrolyte, maintenance and things along these lines. There's just so much intermingling of other subspecialties, as the brain is so kind of intimately involved in every other system of the body. So that was one thing I liked of my rotation in internal medicine, was this huge diversity patients and cases, and it kept it kind of academically interesting over the course of a day. What all you saw.
What types of patients do you typically treat? What are you seeing? What kind of pathology?
So that's the other thing. Like I see all sorts of pathology now. In my practice, I try to focus, on cerebrovascular neurosurgery. So things like patients with aneurysms or arteriovenous malformations or, things along these lines. But that being said, when you're on call, you have to be willing to take whatever is thrown at you. And, I've treated everybody from premature babies all the way up to the very elderly, people from all different socioeconomic classes, all kinds of pathology, be it, taking out a tumor on a peripheral nerve to doing, spine surgery, to taking out tumors in the spine or brain, doing an open surgery to clip an aneurysm, to doing endovascular surgery to treat cerebrovascular pathology. So it's pretty varied, and it keeps things interesting.
Describe a typical day for you as an academic neurosurgeon.
Okay, so I usually get into the office about 6 o'clock in the morning, and it gives me some breathing room to kind of cursorily go over some of the labs and images of the patients from the day before. And I'll usually get up with one of my residents, 6:30, 6:45, around on my floor patients, and then depending on the day, then it's kind of different. So one day a week I'll have clinic, and clinic starts at about 8 o'clock, and that lasts until probably about 5 o'clock, and it's seeing a combination of new patients and my operative follow-ups and things along those lines. A couple of days a week I'll be in the operating room. So these are patients that I've booked electively or that I'm taking care of that have been admitted on the floor from the emergency room. And then a couple of days a week I'm in the endovascular suite. So I'll do things like diagnostic cerebral angiograms or treat things like aneurysms by doing coilings or stentings, and treat carotid stenosis with angioplasty and stenting, treat arteriovenous malformations with sort of glue embolization. And this is something, being 1 year out of residency, I'm sort of in the middle of what's essentially an enfolded fellowship. I did, several hundred cases as a resident, and sort of an enriched curriculum to that focus essentially on endovascular treatment of cerebrovascular disease. And now I'm doing another year under the tutelage of a couple of the guys here at the University of Kentucky, Dr. Justin Frazier and Dr. Abdul Nasser Al-Hajri, that are kind of being my mentors and teaching me through this, so that I can get sort of a certification as a sort of a new thing in cerebrovascular intervention that some other specialties are actually getting in on, things like interventional radiology and neurology, kind of doing these fellowships so that they can become adept at this sort of intervention. But I essentially do that for 2 days a week.
Yeah, it sounds like, I remember a couple weeks ago speaking with the interventional radiologist. It sounds like they do a lot of similar things. Do you? And he talked a lot about kind of the turf war over these procedures. Yeah. Do you see a similar kind of turf war going on?
Luckily not at my institution. Well, one of my mentors is a radiologist. He's an interventional radiologist, and he's amazing. He's been teaching me for the year, and so he's grooming me to be a partner in this practice. So there's no ill will there, no fighting over it. That being said, I think just in general in the industry, I think there is a little bit of protecting your turf from, say, cardiologists or outside, other subspecialties that are trying to get in on it. And there's sort of a move in sort of interventional surgery to try to standardize what a fellowship is, in order to kind of make sure that everybody from all these different specialties, when they come out, when they're doing these procedures, that when a hospital hires one of these folks, that they're getting a comparable product essentially. You know, I think across the industry there's a little bit of, you know, kind of turf wars and wanting to protect your dominion. I guess that's natural, but luckily I haven't encountered that in practice.
Yeah, good. Do you have to take a lot of call in your program?
Right now, no, because there's, you know, starting in July, there's going to be 8 attendings, and we'll split up primary neurosurgery call, you know, amongst us, so it's not bad at all. Now, as far as interventional call, I'll take essentially 1/3 of the call, and we do a week at a time. Though that is much less rigorous than primary neurosurgery call. So we, you know, the things we'd end up having to come in for would be an acute aneurysm rupture that needs to be treated endovascularly, or a stroke. You know, thrombectomy for stroke has really taken off since, you know, February 2015, when a bunch of studies came out that showed that it's a really efficacious intervention. And because of that, it's really opened the door for a lot of people that may not have been candidates in the past to have a mechanical thrombectomy. And for that, you know, we end up getting called in the middle of the night a lot. We're a comprehensive stroke center, so that we've always got somebody on call that can do that, which is nice. But that being said, that call, you know, it's for a week at a time, and we're not getting called in every single night by any stretch. But my, you know, primary neurosurgery call is, you know, every 6 or 7 nights, and that's you know, that's totally manageable and doable. Yeah. It's much better. I mean, I'm fresh out of residency, but we're doing it every 3, you know, or so. So it's a lot better. It's a lot better than that was.
Yeah, it's a brand new life for you.
Oh, it's wonderful.
When you're seeing patients in clinic, you said you have 1 day of clinic a week. What percentage of patients do you typically go on and bring to the operating room or do procedures on?
I'd say it's a very small percentage. I mean, there's some people that are kind of teed up to come in. You know, we get people that are sent to me from, you know, pain clinics and anesthesiologists that are there to have, you know, things like interventional pain procedures done, like have a dorsal column stimulator placed, or an intrathecal, you know, analgesic pump placed, or something like that. And these are people that are coming, and they've kind of already been worked up, and they're coming and they know they're getting a surgery, and you know, those people are definitely going to the OR. But you know, if I look at 10 people I see for back pain, for instance, which is a very common thing that primary care doctors send folks to a neurosurgeon or an orthopedic surgeon for, you know, probably, you know, 1/10 of them or less is going to be something that's worth going to the operating room, and that's going to be after trying conservative management first. You know, physical therapy and, you know, eat, rest, ice, you know, these sort of conservative managements. You know, probably all in all, if you took my entire case mix, you know, maybe, you know, 20% of the people will end up going to surgery, and the rest will, you know, I'll counsel as well as I can with regard to their pathology, and you know, some of these are folks that I'll follow longitudinally for a small incidental lesion that, you know, we'll watch and see how it goes. You know, a small aneurysm, you know, that's worth watching and making sure it doesn't change or develop high grade features or something like that. But you know, for the most case, most people, you know, we try to be conservative with.
Do you feel like you have decent work-life balance as a neurosurgeon?
You know, I don't think any neurosurgeon does. You know, we kind of have a kind of the workaholic stereotype, and I think that's true. You know, to an extent, I have a nasty habit of bringing work home with me, kind of perseverating over things I did or didn't do, and you know, I have 3 small children, and I am happy that I get to spend a lot of time with them. I have a program that does sort of emphasize, you know, having a good you know, home-work balance. I have a chairman that's really wants to make sure we're happy at work, and so a big part of that is making sure you have a good balance in life. That being said, you know, there are a lot of nights where I'm, you know, signing notes or, reading about the upcoming cases or writing papers or trying to do something like that at home. And there's, I don't know, one thing I do wish is that I was, I guess, around for some more of the things that the kids do. They're getting to the age where, they're having more and more sporting events and issues with their school and parent-teacher conferences. And my wife ends up bearing the brunt of a lot of that stuff. But I, making a point to take time out of your day and do as much of that as you can. And, be there for family dinners and kind of making it a real point, when you're tired is how I handle that as best as humanly possible.
Describe your thought process on working in an academic center, finishing your residency and deciding to stay on an academic center versus finding a community hospital.
Well, one of the biggest benefits is that I'm surrounded by a great group of residents, and these are people that, I know and I trust, and I think they're super bright, and I get to play a part in teaching them and helping them to become kind of the next generation of neurosurgeons and kind of walking them through, the same steps that my predecessors did for me. And I think that's huge. I owe all the people that taught me, a debt of gratitude. And that's something that's very, very important to me. It'll always be very important to me, and to play that role in the lives of the upcoming residents, means a great deal to me. The other thing is that being in an academic center, it puts me at kind of the forefront of, what's going on academically in neurosurgery, which is kind of a wide open field. And like Dr. Gray mentioned before on the neurology podcast, there's so much that's not known about the brain, and there's so much research going on that it's really exciting to be kind of on the forefront of that and seeing that happen in real time. We get to a lot of these interventions before the community gets to them, because we're involved in the big multi-institutional sort of research projects, and we get to see a lot of unusual pathology that gets sent to us because it's something that is typically only dealt with in a place like a big university that has the resources and has things like intensivists and pediatric ICU or these other resources that help us deal with kind of unusual pathology sometimes, that it gives us the opportunity to deal with that.
Yeah. Okay. What is the path to becoming a neurosurgeon look like? What does residency and the rest look like?
That can be really varied for one residency to another. There's a lot of wiggle room. Essentially, the ACGME says you have to get a certain number of these different categories of procedures under your belt while you're a resident, and you have to do so much time in an ICU, et cetera. But essentially for me, it was, we graduated from medical school. I spent a year doing an internship where it was half sort of general surgery subspecialties and half neurosurgery and neurology. I think nowadays it's a little bit more focused on neurosurgery and neurointensive care. And then it was 6 years of neurosurgery residency. As a junior resident, I did a lot more of the carrying the call pager, dealing with the ER, seeing new consults, helping staff clinics, helping take care of patients on the floor and the inpatients. And then as I went on and experienced, spent more and more time in the operating room, spent more and more time kind of doing academic stuff, got to spend a little bit of time in the lab, got to kind of, as I sort of alluded to before, mold my curriculum so I could enrich myself in certain subspecialties once I had kind of met my prerequisites in others, so I could try to subspecialize a little bit, and as we got on towards 5th, 6th, 7th year, we took on more of an administrative role as well. We worked with, scheduling where all the junior residents are going to be, and while also juggling, taking care of the operating rooms and being the chief on call and helping the junior residents while they're on the floor, whether it's guiding them with advice, walking them through floor procedures like placing ventriculostomies and lumbar drains and things along those lines, and just basically being a resource for the younger guys. And then it was graduating, which was glorious.
Yeah, there is a light at the end of the tunnel. So,
oh yeah,
7 years total. That's pretty standard for all neurosurgery, correct?
It is. There are some places that allow for enfolded fellowships. There are some people that end up doing 1 or 2 years in a subspecialty afterwards to even further subspecialize. Mm-hmm. These are all optional, but the typical base residency 7 years.
Okay. Is neurosurgery competitive to match into?
It is. I don't know the exact numbers or anything, but I imagine it's getting more and more competitive. I've met some really, really smart, capable, qualified folks over the last couple of years that unfortunately ended up, in the scramble. But I don't know where we compared to some of the other, surgical subspecialties or dermatology or some of the other very sought after subspecialties. I think part of it, maybe because there aren't a whole lot of spots, and there's a lot of very, very smart, capable, qualified applicants.
So is that what you think? Do you think it's more just a supply issue and not necessarily demand? Because it would seem from what you're describing and kind of obviously what I've heard through the grapevines is neurosurgery is hard. 7-year residency, the lifestyle's not the best compared to some other ones out there, but the demand is still there. So is it really just there's just not a lot of programs?
Well, like I said, I think it's a little column A, it's a little column B. I think despite the fact that it's very rigorous and it's a tough lifestyle and it's a tough residency, I think there are a lot of people out there that are up to meet that challenge and take that as a challenge and want to face it head on, and I applaud them for that. There's a lot of great applicants, and the other thing is there are a lot of other residencies out there that are very, very hard: general surgery, orthopedic surgery, plastic surgery, cardiothoracic surgery. These are all really tough. I apologize if I left out any of the listeners chosen subspecialties. There's a lot out there that have tough lifestyles, that have great, super smart med students that want to go into them, and that speaks good things for the future of medicine here. But it does make it tough, and it makes it kind of nerve-wracking come match time. So
yeah, what do you think makes a competitive applicant for neurosurgery?
So, I don't know, everybody probably tells you
good board scores,
board scores, good grades, but and that's like duh. As somebody that's as a chief resident and as a new attending who's been on the the committees to kind of go over all the applicants, I think when I'm looking through these applications, everybody that ends up getting their folder to my table has good board scores and good grades, and when it comes to 10 or 15 points on the USMLEs, that's not what seals it for you. I think it's at the interview showing that you're a reasonable person. I think there's a lot of very, very smart people that also maybe very aggressive and may make for kind of a hostile work environment. You want a good esprit de corps. You want everybody to get along. That makes life nice. Our resident group is gets along with everybody and goes to each other's kids' birthday parties and stuff. And it's really pleasant, and that makes for a much more pleasant work environment. And kind of our match system is difficult because we interview folks for a day, and it's like speed dating for somebody that you're going to marry. We're stuck with each other for 7 years. If we pick each other, we want to put our best face forward and not kind of sugarcoat things. We want you to see who we are, and we want to see who you are. And if we can get the sense that you'll get along well with everybody and you'll play nice. And one of the best ways of doing that is if you're interested in going to a particular place is to do a sub-internship there, or whether it's a month through your medical school or just a week, or, go back for a second look after you've done your interview, just, to spend some time with them. Because that's the other thing. Any residency program can really put on a good face for a day, especially when none of the attendings are scheduling cases and we've got free food for conference and all this other stuff. It makes for a really nice time. But to see how everybody is, on a day-to-day basis, and how everybody gets along, and what that kind of interaction is like, is important. And it's nice for us to be able to see that out of the applicant. I mean, what makes a nice applicant is you being, us trusting that, we can get along with you. I think it's a big, important part.
Yeah, that's good. Since you are looking through these applications, what are your observations as far as any sort of negative bias towards DOs for neurosurgery?
I don't know a lot of DO neurosurgeons, unfortunately, and it may just be because I'm kind of a novice and haven't been out in the academic world for a long time, and I went to an allopathic school and went to through residency at an allopathic program, but I can't really say anything on that. I don't have a lot of experience with neurosurgeon DOs. I know there are some kind of designated DO neurosurgery programs, but I don't know enough about them to speak on them, unfortunately. Sorry.
Okay. No, that's fine. You mentioned some subspecializing earlier. What opportunities are there for somebody 7 years out of residency, or after 7 years in residency, that is crazy enough to want to do more training? What options are available for them?
Sure. So there are a lot of options for you. So pediatric neurosurgery is a kind of a recognized subspecialty with its own board exam. Like I mentioned, for me, cerebrovascular neurosurgery, whether it's open or endovascular, there's something out there now called the CAST system, or Certificate of Advanced Surgical Training, where you basically do an enriched program where you meet a certain amount of criteria, do so many cases, and to qualify for this, and you basically get kind of a certification of that you've done something above and beyond, so that it can be a feather in your cap, but that can be for spine, it can be for epilepsy, peripheral nerve. There's a lot of different kind of subspecialties in neurosurgery. If you wanted to really focus in, to be able to do that, it's nice to be in an academic center where you've got other folks that kind of can cover the rest of the subspecialties. Functional neurosurgery, things like deep brain stimulation. It's nice to have somebody that can do that and provide that service. And while if you want to subspecialize in something else, it's we have a good complement of attendings in our group, and so that makes it kind of nice.
Okay. What do you wish that primary care providers knew about neurosurgery and what you do day to day to make your job easier so that you can do better for their patients?
I don't know. We have a pretty good relationship with a lot of the primary care providers sort of in our area, and they know we're there to help. I think the important thing is for them to know that we're there and that we're available to help with things, even things that may not be necessarily totally surgical. A lion's share of the stuff that primary care doctors send us are things like back pain, neck pain, and sometimes these are things that are much better dealt with physical therapy or a physiatrist. But we're always there to kind of help weigh in on this. They get an MRI on these folks, and it's read as disc bulging and neuroforaminal stenosis, et cetera, et cetera. There's never been an MRI that's ever been read as perfectly normal, and it's hard to make heads or tails of whether one of these is surgical and one of these isn't. And I'm more than happy to go over that in my office with the patient and show them their pictures and let them understand what's going on. I think it helps. It makes people feel that they're being, carefully looked at, and not just saying, you don't need an operation, get out of here, or explaining to them what something means. If they incidentally discover, a small cerebral aneurysm, we're here, have them come to our office. I'm available to talk with them about that. I'll show them pictures. I'll show them their CTA and kind of go over what it means and what the risk factors are and what the, percentages of having a problem related to it are. And, that kind of knowledge, putting somebody's mind at ease, a lot of times is really all they're looking for. So we're here to help, and like I said, we deal with a pretty broad variety of neurological issues. If there's something better served by a neurologist, I'm more than happy to get my neurology colleagues involved, and we can have a multidisciplinary approach at things. So feel free to call us.
You mentioned neurology. What other specialties do you work closest with?
I work a lot with oncology. So we see tumors in the spinal cord and in the brain and in the peripheral nerves. I work a lot with physical medicine and rehabilitation, as a lot of people that come to us with issues of, whether it's brain pathology, they've had a big stroke, and now they're working on getting their strength and becoming functional and becoming independent or ambulatory. Working closely with those groups. We have a great group of rehab doctors that help our patients immensely. We work with the hospitalists. We work with the ED. We work with vascular surgeons. Some of our territories overlap as far as carotid artery pathology and things like that, and so we share some real estate, and it's nice to have a different set of eyes to help weigh in on some of the issues we have. I don't know, trauma surgeons a lot. A lot of the patients they see have brain and spine trauma, and so we work very closely with them. Like I said, neurologists are one of our closer colleagues. They between we share a lot of management on stroke patients, but also things like epilepsy. We're there to we can do lesionectomies or temporal lobectomies. They help us with EMGs and things along those lines when we're trying to elucidate some sort of peripheral pathology. So we end up being kind of closely involved with a lot of different departments. Like I think I mentioned before, endocrinology. So for our Cushing's patients and pituitary tumors and things along those lines. So
a little bit of everybody.
Yeah, I'm sure I'm leaving somebody out again because it's getting late, and
that's all right.
But if I did, I apologize. But like you said, I'm deeply indebted to all these fine folks that help us take care of people.
Very politically correct.
No, seriously, no. I really, I'm in a pretty pleasant place to work where people get along. It's nice.
That's awesome. What are there any special opportunities outside of clinical medicine for neurosurgeons?
Oh yeah, you can run for president. You could be a correspondent for CNN, or I don't know. I think people think brain surgeons are good at stuff other than brain surgery, so we get away with a lot of stuff. I think it's not necessarily true. No. There's a lot of room for us to do stuff in academics, in research, and in the lab. We can help take things from the from the benchtop to the bedside. We have access to the patient base with which to do that, and so that puts us in a kind of a unique situation. I think some of us end up doing stuff in administration, but I think a lot of us are very clinically and academically busy between teaching and writing and and doing our kind of clinical duties, that tends to engulf most of my time. But I think if one were so inclined, you could do pretty much anything, I think.
What do you know now that you wish you knew before starting your residency?
That's a good question. I'm trying to punt on that. I'm not. I don't know.
Nothing sticks out.
Well, I would reassure myself that I'd still love what I'm doing, even after all the grind. There were a lot of times that got kind of tough, and it wears on you. Like I mentioned before, physically and mentally during residency, but that the reward of being able to take care of these people in their darkest hour and be there and be that guy and be involved in the most important part of a lot of people's lives is hugely fulfilling and great.
That sounds like the answer to my next question, which is, what do you like the most about being a neurosurgeon?
Oh yeah. I think see previous answer. It really is nice, and really it's very academically fulfilling. I'd see a lot of different disease processes. It requires a lot of detective work. It's like I said, I get to teach the next generation of neurosurgeons, and these are super bright people that are eager and just an absolute pleasure to teach. You get to teach these great medical students. You get to be very involved with patients. We have patients that want to take selfies with you and that give you hugs, and it's a really good feeling. And there's a lot of folks that get up every day and drag themselves off to work and then drag themselves home, and it's a grind for a paycheck. And I never feel like that. I get tired and things like that, but it's still very, very rewarding and fulfilling.
What do you like the least about being a neurosurgeon?
I don't know. Let's see. There's
got to be something.
There are bad days. There are always bad days, and there are things like you go to sometimes you have a clinic and you just have a streak of a lot of patients that you're not able to help, or you think you did a case absolutely perfectly and you did it textbook and by the book and do everything right, and a patient has a bad outcome, and then that gives you this sort of nihilistic feeling of helplessness. Like, what am I supposed to do? I really had no recourse or no way of changing that. And you present a case at M&M and you still say, if I had a chance to do it again, I'd probably have done it the same way. And if it turns out poorly, you still just sit there and you think about it, and it can keep you up at night.
Briefly describe M&M for somebody that doesn't know what M&M is.
Oh, okay, sorry. So Morbidity and Mortality Conference is it's where you and all of your colleagues sit in a room, and anytime you have a patient that has a problem, either dies or has a complication of some sort, whether it be of omission or commission, their case is presented and kind of picked over academically by your colleagues, and you do this kind of systematically in a way to try to prevent errors in the future. Try to see where in the care and management of the patient did something break down, what could have been done differently, how is this something that's going to need a change in protocol in the future, et cetera, and you try to come up with a solution. It's the idea behind it's great, and
they're stressful.
You should take every mistake as a chance to learn something, but it's very, very stressful, and nobody likes having their problems paraded on a big projector screen in front of a lot of people, but it's important for to make sure that everybody gets treated appropriately in the future, and that it's important for accountability. It's important for teaching the residents. It's important for a myriad of reasons. But it's very, very stressful, and and when it's your case, it's being presented, it's rough on you.
Yeah. Do you see any major changes coming to the field of neurosurgery, whether it's through technology or the way things are practiced?
Oh, sure. I think there's a lot on the horizon. There's so much that's not known about the brain or the central nervous system. That leaves a lot open. But I think some exciting new things that are going on. Things like neuromodulation, so deep brain stimulation for all sorts of different pathologies. Right now, it's commonplace for Parkinson's disease and tremor and things like that. But it's there's a lot of potential utility for that in the future. Some of these implantable devices that help detect seizures and extinguish them before they become a problem. I'm trying to be as broad and use as layperson of speak as possible, but there's a lot of interesting technology on the horizon, and a lot of new utility for old technology, things like vagal nerve stimulators for spasticity and stroke, and there are people that are implanting stem cells for stroke and or for things like Parkinson's disease or neurodegenerative diseases in general. And this is another way that I think we're going to be deeply involved with our neurology colleagues, is kind of coming up with ways where we can potentially intervene and help patients that were once thought to just have progressive neurodegenerative disorders that have promising interventions. Things like the treatments for traumatic brain and traumatic spine injury. Neural computer interface for moving appendages. They've already got stuff that using EEG waves to move a cursor on a screen. These are kind of rudimentary and basic, but they prove a concept, and with a little fine tuning, I don't see it being too awful long before it becomes something that where you're able to use an artificial limb to perform complicated maneuvers. That's very close to being a thing. So
yeah,
we're in really exciting times.
Yeah, it's really cool stuff that's happening. So that's interesting. If you had to do it all over again, would you choose the same residency?
Oh, absolutely.
Yeah.
I've had a great time. I've met wonderful people that are going to be my friends for a lifetime. I had great teachers that, like I said, that I greatly owe, and that will always be kept fondly in my heart. And the field of neurosurgery itself, it's still what I was what I keep by my bedside, is something to read on. That's what interests me. It's even in lay media, it's what I pick up and what I'm drawn to. So it's something that I'm still very, very interested in. Still have a fire for. It's been great so far.
Good. Any last words of wisdom for a medical student that is staring down the gauntlet of 7 years of residency and hearing the lifestyle that it's pretty rough but worthwhile, and is questioning whether or not they want to go down this path?
So first is you could look in yourself and make sure that it's something you want to do, because if it is, then you should do it. I mean, seriously, it's I would recommend it to anybody. Like I've said ad nauseum, it's so rewarding. It's so interesting. Like I said, I absolutely love it. I think there may be a tendency for some folks out in the kind of early med school community to want to be a neurosurgeon, but not necessarily do neurosurgery, and that's kind of the wrong attitude to have. I think TV and such may glamorize the subspecialty, probably inappropriately and more so than other surgical subspecialties, which require just as much scholastic aptitude and manual dexterity and things like that. So look inside yourself, make sure this is what you want to do. In medical school, like I said, I gave a real serious thought to other specialties, knowing that this might make life a lot easier. And in the end, I kept coming back to the neurosurgery books and saying, look, this is what I really like, and this is what I want to do. That being said, you plan it out and keep a balance in your life. Go out and get some fresh air and do some recreational activities that you like. Spend time with your family. These are all important things to maintain, even if you may be tired. It may take a little more effort than it did before, when you were able to, sleep in until your 10 o'clock physiology class or whatever. But once you do embark on that path, try to keep a balance. And I was really lucky that I was able to get into a program that allowed me to do so. So good luck, everybody. You guys have chosen a great field, no matter what subspecialty of medicine you go into. I wish you all the best of luck, and congrats on getting this far.
All right, there you have it. Neurosurgery from an academic neurosurgeon. Neurosurgery is one of those more rigorous paths to becoming an attending, and still as an attending, still pretty rigorous. But as Dr. Gruppige was saying, that there are still a lot of demand and still very competitive to get into it. So if you're interested in neurosurgery, go reach out, go find some programs, go find some mentors. I hope this was helpful for you. If you are looking for a specific specialty that we have not yet covered, I would love for you to let me know, number one. And number two, find me somebody to talk to. That's where I struggle with the most. So that's what I struggle with the most, is finding guests to come on the show. So if you know somebody that would be a great guest for this podcast, let me know. Shoot me an email, ryan@medicalschoolhq.net. Besides that, I would love for you to leave a rating and review in iTunes. It boosts my ego, but more importantly, it lets other people know that the podcast is helpful. And when they go looking for something, they'll see that it has those 5 stars there, and they'll take a listen. So hopefully we deserve 5 stars. I would love for a rating and review. Outside of that, that's all I have. I hope you have a great week, and we will see you next time here at The Specialty Stories.